Welcome back to part 2 of our tutorial of an introduction to child and adolescent psychiatry. My name is Rory Conn. I'm a consultant in paediatric liaison psychiatry in Exeter. Hopefully you've had a chance to look at part 1 with an introduction to this subject, and now we're going to look at, in this second part, the common conditions that arise in under 18s that bring them attention to mental health services. The first thing to say is we look at the developmental approach of the young person, and it's helpful for us to consider in this teaching session what tends to present at one point in the developmental cycle and how that developmental stage influences what we see in the clinic. And then I'll give a brief description of some of the disorders which are the core of the work that we do. So the main psychiatric disorders might be divided into 3 distinct groups. The first are the behavioural or habit disorders, which tend to be seen in younger children prior to starting school or in the first few years of primary school. And these often relate to the interactions of the child with the parent and the environment around them, as we discussed in part 1. And lots of these disorders can be improved through simple interventions and group parenting type techniques. They'll often also find their way to community paediatricians. And as a child psychiatrist, I wouldn't see these too much, although conduct disorders fall in a category where services such as teachers and social services can be involved, and that relates to very difficult, challenging behaviour that may involve the police, for example. The second distinct category we might think of as having more of a general genetic basis. So all of the ones listed here in the second grouping are very strongly inherited, and it's very common to see autism, for example, in other family members. The same with ADHD and other neuropsychiatric disorders like tics and Tourette's. The third category is those disorders which may come on slightly later in adolescence, but tends to have much more of an environmental trigger to them, for example, depression and anxiety. Although, of course, the psychotic illnesses have a strong genetic component too. It's also important to consider the overlap between lots of these disorders, particularly the neurodevelopment and neuropsychiatric disorders. So ADHD, OCD, autism, tics and Tourette's are very often seen comorbidly. And this is a really nice simple chart here at the bottom, which shows how these tend to vary over the lifespan. So if we take the top one, tics tend to originate around the age of 6 or 7. They have a natural history where they will get worse, commonly by age 11 or 12, and they will tend to diminish during adolescence to the point where young people reaching early adulthood may well be free of these difficulties, these movement or vocalization problems. Hyperkinetic disorder, or ADHD, is most commonly diagnosed in the early primary school years and is most likely to be seen as a difficulty in the family shortly around that time. But it's often teachers flagging up that these are young people unable to concentrate or sit still who are causing disruption in the classroom. And ADHD tends to be thought about as a rather static, lifelong problem, although lots of young people who take medication for ADHD will end up coming off it as their brain develops in their early 20s. OCD, obsessive compulsive disorder, is an interesting one in that there is a peak or a surge in early childhood, which often resolves, and then usually in mid to early adolescence is when OCD can become a more pronounced problem. So what presents when? We've covered that a little bit, but in preschool, attachment and bonding issues which relate to the mother-child relationship in particular and can be disrupted by processes such as postnatal depression or family adversity. General developmental problems, which also may come to the attention of a child psychiatrist if we realise that actually This is a child who doesn't seem to be particularly well coordinated, or is struggling with their reading or their writing, and they may have a specific learning need that hasn't been picked up yet, which will be found in the school. Autism we'll come back to. So here is autism, in fact, and for the sake of your exams and your future practice, the main thing is to know that this is a disorder, a condition which is characterized by a triad of problems. And that triad is social functioning and interaction, language and communication, and the tendency to have fixed routines and interests which take precedence over other things. And this is a disorder which is understood to be a developmental process present from the early life. So we cannot make a diagnosis of autism unless we've picked up on particular traits when we take the developmental history that were present from a younger age. Autism doesn't emerge when somebody is in their adolescence or early adulthood. So what we look for in the history is whether this was a young child, perhaps early at school, who would play alongside rather than with their peers. They often might have a rather adult approach in their language and seem sort of pseudo-mature for their age. They might have a specific range of very fixed interests, and parents may say, well, they only wanted to play with Thomas the Tank Engine for 3 years straight, and they wouldn't talk about anything else, and they couldn't really understand why others didn't want to do that. And we also may pick up on specific sensory sensitivities which are common in autism. For example, children being very picky about certain foods. They don't like the crunch or the specific taste. The child that will never wear shoes or collars because they find them intensely unpleasant. And kids generally who find it difficult to express themselves and understand what it is that others are saying or feeling, and are very literal in their interpretation of the world and black and white in their thinking. Autism has been around as an idea for a long time, actually, getting on for sort of 80 years. And Kanner first described it, and he said that these were young children coming into the world with an innate inability to form usual biologically provided affective contact. That's emotional contact. Lots of things that we take for granted, that we can understand from someone's body language what they're thinking or feeling, and that we can understand abstract language, and those are the things that young people with autism will find particularly challenging. The concept of mentalization here refers to the ability to be able to predict what another person is thinking or feeling, and that is absent or lessened in autism. So there's the triad, and I want you to remember that, particularly for your exams. So in middle childhood, we tend to see ADHD presenting as a problem, as I said, with school referrals, tic disorders, anxiety. School refusal tends to come along at the point in which social difficulties and anxieties are arising. Educational difficulties, I've mentioned conduct disorder. And depression tends to come later. It's very unusual to see a child under the age of about 12 or 13 who has a diagnosable depressive illness. It tends to happen more in adolescence. For tics and Tourette's, I'd recommend that if you have time or interest, you have a look at the talk that I've given recently on this, and there's a video link at the end of the presentation to a YouTube talk on that. ADHD, attention deficit hyperactivity disorder. For a long time, this was a rather controversial condition, but it is now well established, at least within the medical community. Again, this is a neurodevelopmental problem in which the brains of young people with ADHD struggle to concentrate and seem to be overstimulated and unable to focus. The core features, again, it's a triad of difficulties, are overactivity, inattention, and impulsivity. So the classic case we might see coming into community paediatrics or to CAMHS would be a description of a 5 or 6 year old child whose parents say they've always been very challenging to manage. Their sleep has been always very problematic, jumping out of bed repeatedly, intrusive in people's faces, very demanding of attention, but equally not seeming to pay attention when others are talking to them. They lose track of concentration, they can't follow instructions, and they tend then to act out, which is a phrase which means expressing through their behaviours some of the frustration that they might experience. So these are kids who might be labelled as naughty, but might actually have an unmet neurodevelopmental need. Impulsivity is commonly seen in that these kids might repeatedly run out into the road without looking. They might act in a way that seems cruel or unthinking by saying things that other young kids might be learning that they have to regulate before speaking out loud. And these things, again, can get kids into trouble. This is a neurodevelopmental disorder, and the thinking is that the prefrontal cortex, which manages our emotional state and helps us to keep a lid on things, quite literally, isn't talking well enough to some of the primitive areas of the brain, the sort of fight and flight mechanisms, and so kids will act very impulsively and sometimes aggressively. The prevalence is significant, so if we screened all kids in all classrooms, we'd pick up a lot of untreated ADHD. Boys seem to be more commonly affected as they are with autism than girls, perhaps as much as 3 or 4 to 1. And there are associations with other developmental delays, both motor and cognitive, and we'd be more typically expecting to see ADHD in a young child who might have a learning disability as well. So treatment, absolutely the first line is behavioural. We do not reach for our medication prescriptions quickly here. And psychoeducation means educating the young person about the nature of their condition, educating the family and the school in terms of how to adapt and how to structure the day, how to give clear instructions, and quite have a regimented but thoughtful approach to this young person. And there should be access for parents to go to groups and have specific training on how to manage their child in this regard. If all of that has failed, and it's very much the second line, we might use medication, and the mainstay of treatment is stimulants like methylphenidate. The question that often arises from medical students quite sensibly is, why would you give a stimulant to a young person who seems overstimulated? And that seems rather perverse or confusing. But in the same way, there's a parallel in which alcohol, which is a depressant and something which will, in theory, slow people down and sedate them, is also something that makes people at parties more animated and more gregarious. So we don't exactly know why this happens, but it seems to be that the stimulant affects the areas of the brain specifically that are struggling with attention and concentration. We have to be cautious in the prescription of these medications because they can be illicit substances and used for a stimulant effect and sold as a street drug. The prognosis for ADHD, well, this is a condition that can cause significant impairment, and lots of young people, for example, who are go on to be adults having lives in prison, actually had ADHD as a child and it was never picked up on. The response to medication can be dramatic, and it's one of those moments in psychiatry that we might prescribe a medication and literally a few days or a week later the family say it's like having a different child in a very positive way. They're now coming up and giving us hugs more spontaneously. They're waiting their turn. I'm not shouting at them. They seem to be enjoying school more. Their friends are now inviting them over for play dates. So we have lots of very positive response to this. But it's well recognised now that ADHD can persist into adulthood, and despite the fact that most discontinue medications around this time, there are plenty of adults in the workplace who struggle with ADHD. Anxiety is a normal life experience and part of normal development, and these are the classic things that chronologically children and young people tend to be anxious about. As infants, it is normal to be scared of strangers, to be scared of being left alone. age between 1 and 2, and then that progresses on to fear of things like animals in age 3 to 4, more abstract things like ghosts 5 to 6, and then things like school phobia developing a little later on. So these are normal, but if these are held to an extreme extent, they can be quite debilitating. Some of you will go on to be community paediatricians, and it's worth thinking about the overlap between paediatrics and mental health in this regard. So paediatricians need to know a lot about mental health, and actually there are a set of conditions where psychiatrists and paediatricians need to work together with a patient and family as a marriage of mind and body. The classic is in somatisation, that is to say medically unexplained physical symptoms, which are extremely common in children and young people. So as many as 30% of those under 18 have chronic somatic complaints, most commonly abdominal pain, which affects 10% of the school population. But also there are tons of kids being referred by GPs for headache, for fatigue, for motor weakness. And these are often understood, if you like, take a holistic view of the young person, as a bodily representation of emotional distress or confusion. And kids don't have what's called the emotional lexicon, that is to say, the ability to put into words what they are feeling. And so often, unfortunately, these kids get multiply over-investigated by well-meaning paediatricians, whereas if they had had a joined-up approach early on to understand the formulation, we might learn that they were being bullied or suffering in some other way. And what's really important is how people respond to something like abdominal pain. So this is from a good paper in the BMJ that shows that family life and parental response to pain are just as important in how pain is perceived by a child as all of the physical factors. In later childhood and adolescence, that's when we might see mood disorders. That's a separate lecture really, but you would expect in childhood the same symptoms of depression to be seen as in adults, although irritability is well recognised both as a normal part of being an adolescent, but also as a potential presenting feature of adolescent mood problems. It's uncommon that we see bipolar disorders because they tend to emerge in the early 20s, really manic illnesses, but we do see a small number of kids with bipolar illness. OCD and PTSD, I think, are probably beyond the scope of this particular talk. Eating disorders I'm going to touch on. Anorexia nervosa is the most common eating disorder that we would come across, and unfortunately it is quite common and increasingly so. The cardinal features of anorexia nervosa are a body weight of 15% below what would be expected for that child's age and height, and we recognise the problem as being anorexia nervosa when there is intentional weight loss alongside a distorted body image, a fear of fatness, and particularly in girls, endocrine dysfunction. So an adolescent girl who's lost a significant amount of bodily weight is reporting, often with a lot of encouragement, these cognitive difficulties, and has stopped menstruating, is likely to meet the criteria of anorexia nervosa. The mainstay of treatment is family therapy in young people, and medications have a very limited benefit in anorexia nervosa, but comorbid other mental illnesses like anxiety and depression needs to be treated. Additionally, we increasingly recognise there's an overlap between anorexia nervosa and the neurodevelopmental disorders. So teenage girls presenting with apparently anorexic symptoms, we need to think carefully about whether they might have undiagnosed autism. It's worrying because it's the most fatal of psychiatric conditions and often quoted as a 1 in 5 death rate, and about the same in terms of young people who don't recover and go on to have lifelong difficulties in relation to their body and eating. Self-harm isn't a condition in its own right, but it's worth mentioning here. It is common, increasingly so in adolescence. We need to make the distinction between self-harm and those who are trying to end their life. Parasuicide is an attempt to end one's life that doesn't end in completed suicide, and may also involve self-rescue, for example, taking a small overdose and then seeking help immediately. Self-harm can take many forms. Everyone is aware of the idea of taking overdoses and cutting, but there are many other forms, including boys punching walls, for example, or people intentionally neglecting themselves in various ways, or putting themselves in risky situations. That can also be a form of self-harm. Mostly it is impulsive, but people can get into intractable cycles of self-harm, and it's very unusual for a young person to say that they enjoy self-harming, but each will have a different report of how it affects them and why they harm themselves. Intentional suicide is a very rare outcome in young people, and in under 12s especially very rare, but suicide nonetheless is still one of the most frequent methods of death in young people, because death in kids is unusual, and risk management of young people who are suicidal is of course very important. I'll touch on hallucinations again just to say that this isn't a conditional diagnosis in its own right, but we do get quite regularly referrals from GPs and paediatricians about young people hearing voices. So the definition of a hallucination is when a perception is perceived without an object to explain it, and that can be in any sensory modality. So a child who is hearing voices or seeing things when others apparently cannot do so. So they are not pathognomonic for psychosis. If a child is hearing or seeing things that seem bizarre, that doesn't mean that they're psychotic. And these are symptoms also reported in states of acute anxiety, in autism, and in young people who are struggling to regulate their emotional states, some of whom will go on to get diagnoses such as personality disorder, which is not a diagnosis we tend to make in young people with developing brains and personalities. If ever a young person presents with visual hallucinations in particular, we need to be very careful that we've ruled out organic causes for those, for example delirium, but also might there be an unusual epilepsy that's presenting with this. So it is organic until proven otherwise. You'll hear in other lectures from your psychiatry teaching about the importance of distinguishing internal versus external perceptions. So a psychotic voice would tend to be experienced in the external world, as if the voice is in the room with someone, versus a voice perceived in the internal space, which is more likely to be a projection of a thought a young person has themselves. And hallucinations, particularly auditory ones, are very common in young people, up to about 8% of the population. These tend to be thoughts about themselves which are split off in some way in terms of their psychological development. Finally, I was asked to cover the legal frameworks in this age group, and the simplest thing is to say the following: there is no lower age limit to the use of the Mental Health Act. So in theory we can detain a 10-year-old under a section of the Mental Health Act, but it tends not to happen in that way. Under 18s, like adults, are assumed to have capacity until proven otherwise, and they can consent for their own treatment. So please read up about Gillick competence in that regard. But the other thing to have a working knowledge of is the Children's Act, which allows us to give treatment, usually not psychiatric, but medical, for medical problems, to children with the consent of parents, when that treatment falls within what's known as the zone of parental control. That is to say, what is reasonable for a parent to agree to on the child's behalf when the child is unable to understand, for example, the nature of the problem. Here is a couple of links to some lectures which are available to you on private YouTube channels through Devon Partnership Trust, one on tics and Tourette's that I've mentioned, and also some further teaching on consent and capacity in young people, which is a particularly difficult area to get your head around. Thank you very much for listening. I hope you found it interesting. Please do follow me on Twitter, where I post about psychiatry, and you can sign up to be an associate member of the Royal College of Psychiatrists for free and get lots of access to things there, and join your local psych soc as well. Thank you very much.